Hi, my name's Nick and I'm a neurology registrar. In this video I'm going to talk about all the primary headache disorders that you need to know for your medical school finals. We'll classify our headaches according to the International Classification for Headache Disorders, which divide up headaches into two types, primary headaches and secondary headaches. This video will focus on primary headaches, which make up about 90% of all headaches. Primary headaches are conditions in which the headache itself is the disorder, and secondary headaches are conditions in which the pain is as a result of some other underlying pathology. There are three main types of primary headaches: migraines, tension-type headaches, and trigeminal autonomic cephalgias. Migraines are the most common, so let's start with that. Migraines are severe throbbing headaches. They're usually unilateral but can be bilateral. They're often associated with other features such as nausea, vomiting, photophobia, and phonophobia. Often migraineurs get into bed and try and block out the light because light and movement in particular can make the headache worse. Migraines can be really debilitating. They can wipe people out for a day or even a few days. Some migraineurs experience a prodrome in the days preceding a headache, and these can consist of mood or behavior changes or hunger cravings or fatigue. Some migraine sufferers experience an aura. These are visual, sensory, or other central nervous type symptoms that occur a few minutes just before the headache starts. The most common type of auras are visual auras, which usually present as fortification spectra, which are zigzag type lines in the patient's field of vision. These usually spread outwards to leave a scotoma in their wake. Sensory auras can be experienced as pins or needles in the body or the face. Auras can also present as speech disturbances or aphasia. Migraines can be triggered by certain foods or smells such as cheese or alcohol, and they can sometimes be associated with hormonal changes during periods or pregnancy. One of the most useful investigations in migraines is asking the patient to keep a headache diary, in which they mark the number of days in a month they experience the headache, how many headaches they get on each day, and the severity and duration of each one. This can then be used to monitor response to any treatment that you decide to give later. The management of migraines can be divided into three main categories. 1. Lifestyle measures. 2. Acute medication. And 3. Preventative medication. Addressing lifestyle measures can make a big difference to some migraine sufferers, and this includes discussion around reducing stress levels, ensuring good sleeping patterns, ensuring good hydration, and regular exercise. You can also counsel them to reduce exposure to certain triggers such as caffeine. Moving on to the second category, acute pain medication. There are various options available, including triptans such as sumatriptan, non-steroidal anti-inflammatory drugs such as ibuprofen or naproxen, or even just paracetamol. High-dose aspirin can also be used, and sometimes a combination of a few of these are used together for maximal benefit. Giving them in conjunction with antiemetics such as metoclopramide, domperidone, or cyclizine can be useful in reducing nausea. In patients who are experiencing very frequent or debilitating migraines, drugs can be given to reduce the frequency, duration, severity, or intensity of the headaches. There are lots of options available, from tricyclic antidepressants such as amitriptyline, angiotensin receptor blockers such as candesartan, beta blockers like propranolol, and even topiramate, which is usually used as an antiepileptic. The choice of drug depends on the patient in question, taking into account the side effect profile in conjunction with the patient's lifestyle and comorbidities. The second type of primary headache disorder are tension-type headaches. These are usually bilateral, quite mild headaches, classically described as a band-like sensation around the head. They're self-limiting and usually don't require any medication. If medication is required, then a short course of simple analgesia such as paracetamol can be useful. The mainstay of treatment involves counseling the patient to reduce stresses in their life and maintain good sleep and hydration. The third and final primary headache disorder are trigeminal autonomic cephalgias. This is actually an umbrella term encompassing a number of different headache syndromes, but the most common of these is cluster, and this is the one you really need to know about. Cluster headaches usually present as severe unilateral or periorbital pain. They sometimes feel like a stabbing sensation or a screwdriver driving into their head. They can be extremely painful to the patient and cause a lot of agitation, even to the point of making some sufferers commit suicide. They tend to occur in males more than females and usually last around 15 minutes to 3 hours. As the name suggests, they can occur in clusters, where patients would experience one headache a day for a period of weeks or months. Sometimes they occur on a yearly basis, in which case the patient might report that they occur in a particular season of the year or the same few months each year. Sometimes they're associated with what are called cranial autonomic features. These include conjunctival injection or lacrimation, where one of the eyes becomes very red or starts to produce tears, nasal congestion or rhinorrhea, facial or forehead swelling, or miosis and ptosis. The treatment of cluster headaches involves triptans, or if the patient happens to be in hospital, administration of high-flow oxygen. Verapamil, which is a calcium channel blocker, can be used as a preventative medication. So that is a brief overview of the primary headache disorders. Remember that most headaches are primary headaches, so these are the conditions that you should be thinking about when a patient presents with a headache. In another video, we'll talk about secondary headaches. These are much less common but are really important to pick up, because they can be a sign of another serious underlying pathology.